Good afternoon. I guess we're here to have our little discussion about cholesterol and atherosclerosis, which is the other pandemic. And I will just make a few introductory remarks as we wait for a few more people to sign on to this webinar. But my name is Dr. Michael Koren. I'm a cardiologist and clinical researcher and the CEO and medical director of Jacksonville Center for Clinical Research. We are a clinical research site where we help develop new cardiovascular products and also are involved in testing to make sure that the current products that we have on the market are as valuable and successful and safe as possible. So we get involved in all those different programs, and the activities here are funded by various entities, including pharmaceutical companies, the government, foundations these days, and a number of other sources. So when people come to our center and get involved in any of the projects that we have ongoing, fortunately, they can do it completely free of charge since all these activities are funded by outside grants. So it's a nice opportunity for patients to get a lot of information and sometimes interesting therapies without any cost. So one of the discussions that has occurred amongst myself and my colleagues is whether or not the COVID crisis has had an important unintended consequence. And that unintended consequence is that some of the other very serious problems that we deal with on a day-to-day basis may have been overlooked or overshadowed by the concern about COVID. And you'll see on the data that I am about to provide that while certainly COVID-19 is a very serious public health concern and challenge, there's another pandemic out there that's been going on for many, many, many years, which takes as many or more lives than the COVID-19 crisis. And certainly we don't want to drop the ball on dealing with this pandemic, which is called atherosclerosis. And atherosclerosis is the general term that we use for hardening of the arteries, which involves processes that eventually result in heart attacks and strokes. So with that introduction, I'm going to move forward and start to look at the slides that we put together for this presentation. So when we look at cardiovascular disease statistics, it's actually both good and bad news, and I'd like to talk a little bit about both of those things. First, the good news is that cardiovascular death rates have actually dropped by 50% or more over the last 20 years, which is truly remarkable when you think about that. There are very few diseases where we've had such a big impact. And that's due to a number of different things, but most people believe that the most important elements of the drop in cardiovascular disease death rates is due to better treatments. So for example, when you get into a hospital with heart attack symptoms, we take care of you very efficiently these days, and most people have very good outcomes. But also prevention has come a long way. And prevention includes a number of different medications and also diet. Our diet in general has improved quite a bit over the past 20 years, both due to choices that people make and to manufacturers that are making products with better ingredients. But despite the progress, there's also some bad news, is that 92 million Americans as we speak have cardiovascular disease. And every 40 seconds, there is a death in the US either related to heart attack or stroke. And there are 60,000 US deaths per month due to heart disease or stroke. So just to put that in perspective, since the beginning of the COVID-19 crisis, which hit the US in January and affected us in February, March, April, and May, during those 4 months, we've lost somewhere between 100,000 and 110,000 people, unfortunately. During that same period of time, we've probably lost about 240,000 people due to heart disease and stroke. So even in the worst month, which was April, we had about equal numbers of patients dying from COVID-19 and from cardiovascular disease. So while there is a tremendous amount of attention regarding COVID-19, there probably should have been equal attention on preventing heart disease and stroke since they were equal killers at that time. But over the course of the year, we expect that cardiovascular disease will take many, many, many more lives than COVID-19. The other concern is that cardiovascular disease is projected to rise. As people get older, they tend to be more prone to cardiovascular disease, and our population, as most people are aware, is progressively getting older, which is a good thing, especially for those of us that are in the second half of our lives. So one of my focal points for my research is about cholesterol issues. And one of the reasons I'm particularly interested in cholesterol issues is because cholesterol, as you will learn, is what we call a modifiable risk factor. So what is cholesterol? Simply, cholesterol is a waxy fat-like substance that's found in many cells of the body. In fact, every cell of the body, including your eyelashes. And the reason why cholesterol is actually very important is that it is part of every cell. It's a fundamental part of every cell. In fact, the membrane of every cell is made out of cholesterol. And because cholesterol is such an important chemical to our bodies, every cell in our body has the ability to make cholesterol from raw materials. So you don't actually even have to ingest cholesterol in order for you to use cholesterol in your body, which is very interesting and something that people don't always know about. But the problem for many people is that they produce too much cholesterol or they consume too much cholesterol. And what happens is that you overwhelm your body's ability to actually get rid of it. So again, think about that. All the cells in your body are making cholesterol, and they're doing that on a regular basis. And if there's an overproduction of cholesterol, your body has to have a mechanism to get rid of it. And that's where we often fail in terms of our physiology, and that's where modern medicine can help. The other thing we like to talk about when we talk about cholesterol is mention the fact that it is a modifiable risk factor. So a number of different risk factors for cardiovascular disease. As we get older, we have higher risk. Men tend to have higher risk than women. People certainly have family histories of heart disease that have higher risk than people without family histories of heart disease. So all these things are elements of being human that we don't have any control over. But your cholesterol level is something that you do have control over. So from that standpoint, we are particularly focused on that because we can do something about it. So I'm going to talk about the good and the bad cholesterol. So this is, again, an area that sometimes is a source of confusion. And the reason it's a source of confusion is that when we talk about the good and bad cholesterol, we're not talking about the cholesterol in the cells. We're talking about the cholesterol that circulates. And as I mentioned, most of that cholesterol is just destined to get out of the body. Since all of our cells are making cholesterol, all of our cells are delivering cholesterol to the circulation, and our circulation needs to get rid of it, and that happens through the liver. Now, if the cholesterol in our bloodstream is circulating in what's called HDL, or high-density lipoprotein, that's a good thing, because that makes it easier for the liver to remove cholesterol from the body and get rid of it. And what the liver does is that it identifies these HDL molecules that have a lot of cholesterol in them, pulls it out of the circulation, and deposits it into the bowel, and it's removed in the stool. The bad cholesterol is LDL cholesterol, which is the form of a lipoprotein, and I'll get into that in one second, which is less favorable. And it's a type of lipoprotein that actually can cause damage to your blood vessels. And as you'll see in a little bit, the way our bodies get rid of LDL is something we can modify and make a huge difference for people. So a couple of things just as learning points. We use the term lipoprotein. So cholesterol in itself is just this fatty substance. But the lipoprotein is a combination of cholesterol and other fats with protein that actually circulates in our system. And when you think about that, that makes sense. Cholesterol is a fat, and we know that fats don't dissolve in water. So our bloodstream is mostly water, and what the lipoproteins do is allow these fats to circulate so they can go from one place in the body to the other. So again, HDL is a good form of lipoprotein that makes it easier for the liver to get rid of cholesterol. Bad cholesterol is LDL, which is less favorable in terms of removing it from the body and more prone to damage of the blood vessels. Now, we sometimes use the word cholesterol a little less precisely, and really what we're talking about is other types of fats. So another type of, quote, fat is called triglycerides. And triglycerides are a type of fat that our body uses for energy. And it's set up in a way so that if our body needs an extra burst of energy, it can quickly go into your fat cells and call on triglycerides to provide energy for the body. And you'll hear more and more about triglycerides as a risk factor for disease, but it's also a risk factor that's a little bit more difficult to control and manipulate. The other thing about triglycerides is that it's highly dependent on your diet in terms of measuring it. So if you just had a few drinks or you had a very sugary meal, your triglycerides may skyrocket. So we tend to want to measure triglycerides after an overnight fast. Another very important lipoprotein is called lipoprotein A, or what we call Lp(a). And this is a very interesting lipoprotein because it seems to be most profound and most risky in certain families. So everybody has very low levels of lipoprotein little a that don't seem to affect them very much, but there are certain families that have extremely high levels. And families that have extremely high levels of this lipoprotein tend to have more heart attacks and strokes. So a very common scenario in my cardiology practice is to talk to somebody who's relatively young, say 30s, 40s, or 50s. They tell me that both my parents died of a heart attack, or on my father's side, we had somebody die at age 40, somebody had a stroke at age 45, somebody had a heart attack at age 36, etc. And then you take their blood test, which is a specialized blood test, and find that they have very high levels of lipoprotein little a. And as you see, this is a lipoprotein that we have been less successful in treating until very recently. And there's some really, really interesting research that suggests that over the next 5 years, we'll be able to help people tremendously with this congenital or genetic problem. So let's just talk about the dangers of high cholesterol. So high cholesterol affects people differently depending on your genetics and your diet and other things. But people that have serious complications can have some cosmetic effects. There's something called xanthomas, which are basically yellow deposits that people will typically get on their eyes, below their eyebrows. You can get it on the back of your hands and other tendons. And they're these basically fatty deposits you may have seen. You've probably seen people in the supermarket and elsewhere with these xanthomas. So it's a bit of a cosmetic issue, but it's also an indicator that your body is not able to process cholesterol appropriately, and it's ending up in your skin and other places in an effort to get it out of your circulation. The more serious complications of high cholesterol are when you get blockages in the heart arteries or in the arteries that go to the brain or the arteries that go down to the legs. So the type of problems that can occur from that are angina pains, which is your heart not getting enough oxygen and causing a tightness or a constriction of your chest. A heart attack, where actually part of your heart muscle is damaged, and that can lead to serious complications, including sudden cardiac death. Or a stroke, which is when you don't get enough blood flow to your brain and you have some neurological dysfunction. It could be loss of sensation, loss of speech, loss of bowel and bladder control, or the inability to move an arm and a leg. There's many other complications. Some people will get claudication pain, which is pain in their legs when they walk, and multiple other complications, including aneurysms of different parts of the body. So there are many, many dangers of high cholesterol, and they manifest differently in different people. Sometimes we understand why certain people are more prone to strokes or heart attacks, but often we don't. So there's a big overlap. So people that have had heart attacks are going to be at higher risk for strokes and vice versa. So as I start off with, there are modifiable risk factors. And these are the things as physicians we like to put the greatest emphasis on because it's the thing we can do the most about. We can change it. It's modifiable. As I mentioned, cholesterol issues are one of the most modifiable of all the things that we can treat, because we have really quite excellent drugs to change your cholesterol level, particularly your LDL level. And I'll get into that in more detail. But that's not the only modifiable risk factor. Diabetics have modifiable risk factors. We can improve your sugar level. We can help you become less likely to have complications of diabetes. People who are overweight tend to have higher blood pressure, more likely to get diabetes, more likely to have high cholesterol. And by losing weight, and there's lots of ways to help people do that, we can have a huge impact in the likelihood of people developing a heart attack or stroke. Lack of physical activity is something that is modifiable. Obviously, sometimes it's hard to get into a routine where you're doing regular exercise, but it's really quite important in terms of your long-term health. Poor diet decisions. Cigarette smoking is a relatively easy thing to adjust. It's a hard habit to break. We have a lot of tools out there in terms of nicotine replacement or other products that help people get over the habit. And high blood pressure and stress are other things that are modifiable. I'm not going to be talking a whole lot about that today, but just keep in mind that cholesterol control is a really, really important way of modifying your risk, but not the only way. And again, this should be somewhat self-evident at this point, but there are things that you cannot modify. So you can't, I always like to tell people that one of the most important things in life is to choose your parents well. Well, obviously we don't get a choice for that. So we're stuck with our family history. We're stuck with our age for the time being. We're stuck with our genetic gender, of course, where we have our ethnicity that's been given to us, and we can't change the weather either. And you may think that that's a funny thing to put in, but It's been shown that things like hurricanes and the stress that comes with that, or earthquakes, will actually impact people and lead to increased rates of heart attacks. So there are things that we just cannot modify, and we're stuck with those. As I mentioned, family history is one of the things that we cannot modify, but we can understand it to a point where we know who's at highest risk and then intervene. So one of the most common genetic conditions that is related to cholesterol is called familial hypercholesterolemia. And this can be inherited from one or both parents. And if one parent has it, the likelihood of a child having it is about 50%. So this is an important condition to know about, because about 1 in 250 to 1 in 500 Americans have this condition. And if you're identified with this condition, typically you're going to be at very high risk for heart attack or stroke. In fact, most men with this condition will have their first problem, be it heart attack or stroke, in their 30s, and women will typically have their first complication in their 40s. So if you have this particular genetic condition, it's very important for you to be identified by a physician that understands the condition and then treated with this, typically with cholesterol-lowering medication. Now, we're going to kind of jump into some of the medications at this point. And the medicines that have been available now since the late 1980s are called statin drugs. And statin drugs have had a lot of discussion and a little bit of controversy, but the fact is that the #1 side effect of statin drugs is that you'll live longer. So if you look at all the studies, virtually every single study that's ever been done with statin drugs have shown that people will have fewer heart attacks and strokes. And if you let the studies run long enough, ultimately you'll find that people will live longer because of the effects of statins. And the primary effect of statin is to lower LDL or bad cholesterol. The first statin on the market was called lovastatin or Mevacor, which is the third bullet point on this slide. And that's still on the market, but there have been other statins developed that are more effective. For example, atorvastatin or Lipitor and rosuvastatin Crestor are considered the 2 most effective statins on the market. And they're both generic now, so they're actually available at a very, very low cost. There's some technical issues why certain statins may be better than other statins for certain people. But the fact is that statins are now readily available, inexpensive, and a wonderful first line of therapy for people with hypercholesterolemia. And quite frankly, 90% of all my patients who have cholesterol problems are completely adequately treated just with statins. So for the vast majority of patients, they really need very little more than that for their cholesterol issues. But there's some people that need things other than statins. And the 2 main reasons are, 1, people that have extremely high levels of LDL cholesterol that are not lowered enough by statins. So statins at their maximum doses will lower your LDL cholesterol about 50%. But some people need more than that. Some people need to have their cholesterol lowered by 60, 70, or even 80%. And for those folks, statins alone will not be enough. And then the other group of patients are people that have side effects to statins. The most common side effect of statins are muscle aches, but there are other issues that people develop. Sometimes it affects the liver, although that happens pretty infrequently. Sometimes it'll have effects on memory, although again, they're usually very, very minor issues and very easily dealt with. But the muscle issue is something that does trouble people, particularly people who like to exercise, because by the nature of their mechanism, statins will reduce a certain chemical in your muscles called ubiquinone. And people seem to sense their muscles differently when their ubiquinone levels are lower in their muscles. Now, there's some mitigating factors for that, which I won't get into for today's lecture, but nonetheless, there are people that have a difficult time with statins. Fortunately for those people, we have a number of alternatives. The leading alternative is called ezetimibe, or Zetia. It's a drug that reduces cholesterol absorption in the intestines, and that can help lower your LDL another 12 to 15% on top of what statins can do. At a maximum, not everybody has that good of an effect, but it's a drug that has been shown to have positive outcomes in clinical trials. So using Zetia on top of statins is something that certainly can help people. There are other drugs called bile acid binding resins or bile acid sequestrants, and some of the names are listed there. They bind cholesterol in the gut and prevent it from being absorbed. Niacin is a vitamin, it's a B vitamin that actually will lower your LDL a little bit, boost your HDL, and seems to have some mild effects. Unfortunately, when we've used statins with, when we've used niacin with statins in clinical trials, we really have not seen any positive effect in terms of reducing heart attacks and strokes. So niacin's kind of falling out of favor. Fibrates are a class of drugs that lower triglycerides. They have a slight HDL raising effect. We use those in people with high triglycerides. Omega-3 fatty acids are very effective, particularly for patients with triglycerides, and also for patients that are just at higher risk for cardiovascular disease. And we'll talk a little bit more about that. And the most recent addition to our statin alternatives are called PCSK-9 inhibitors. And we'll talk a lot more about that. And we've had the good fortune here in Jacksonville to have a very big role in the development of these products. And as we'll talk about, these are monoclonal antibodies that bind a bad protein that's responsible for blocking our body's ability to clear cholesterol from the circulation. So let's talk about PCSK9. So PCSK9 stands for proprotein convertase subtilistin kexin type 9. Don't expect anybody to remember that, but something that I like to remind people of is a naturally occurring protein. And we're not exactly sure why we have this protein in our body, but it's part of a series of proteins that you can see has at least 9 members of it, because it's the 9th member of this whole series of proteins. And this protein has one very bad effect. And the very bad effect of this protein is that it prevents a receptor in your liver from removing cholesterol from the circulation. So when PCSK9 is not present in the circulation, your body is much more efficient at removing LDL cholesterol, because the receptors in the liver that help remove cholesterol can recirculate over and over and take a lot of cholesterol out of the circulation. But when PCSK9 attaches to these same receptors, the receptors do not recycle and they get destroyed in the liver instead of picking up more cholesterol molecules. So the net effect is that PCSK9 prevents the removal of LDL cholesterol from the circulation. The other thing that's interesting is that we learned that one of the limitations of statins is that they actually increase your liver's tendency to make PCSK9. So with that, we find that statins will have some limits, and that's why even increasing your doses of statins doesn't get you anywhere after you lower your LDL about 50%. You can double or triple the dose of statins and you won't really see a benefit, and you might see some toxicity to liver when you get really high doses of statins. So for that reason, we have limits to the dosing that we use for statins. But once you get to that limit of the ability of statins, the use of a PCSK9 inhibitor helps the statins to work better and will help your body to remove more cholesterol from the circulation. So this particular area of research has become the most compelling area of lipid research really over the past 10 years or so. And this slide is busy, but basically it shows that there are many, many different companies and many, many different entities that are working on ways to help address the problem of circulating PCSK9, which leads to higher cholesterol levels. And as mentioned, there are 2 products on the market, one called Praluent or alirocumab, the other called Repatha or evolocumab. And these are both products that we helped develop here in Jacksonville. And they're both products that are on the market, and they're both products that have been shown in very large studies to improve prognosis. So people that take these drugs are less likely to have heart attacks, less likely to have strokes, and much more likely to do better over the course of 2 to 3 years. And in a study that I actually had the privilege of being the main author for, we've seen that over 5 years, these drugs are safe and very well tolerated. So these are available on the market. We have been involved in the testing, and we continue to be involved in testing these products because there are still unanswered questions. So for example, we know that they work really well in patients at high risk, but do they work equally as well for patients that are maybe at lower or moderate risk? And that's a study that we're doing right now and a question we're asking right now. So people that might be interested in being part of that program would be able to use an approved drug that's been on the market now for about 4 or 5 years and be part of also the process of understanding if we should expand the use of these type of products. But looking on the list, you see that there's many other types of products that we're using that have different approaches to solve this issue of how to get cholesterol down when statins no longer are doing the trick. So One of the things that's really been exciting from a research standpoint is we have a much better understanding of genetics now than we did 20 years ago. And more of the products that we're developing to help people are genetically engineered. They're based on our understanding of genetics. So I just talked about antibodies, and antibodies are something that circulate in our body all the time. We have antibodies that protect us against diseases, but antibodies also can neutralize the effects of bad proteins. As I mentioned, PCSK-9 is a bad protein. So we've actually developed antibodies that will identify PCSK-9 and prevent PCSK-9 from doing any damage to our livers, because the antibodies bind the PCSK9 so it can't bind the receptors in the liver. And this has resulted in a remarkable ability to reduce cholesterol on top of statins. So when we have a patient that's already on statins and we give them a PCSK9 inhibitor, we may see additional lowering of LDL cholesterol by another 50, 60, or even 70% on top of that we see with statins. So between statins and PCSK9 inhibitors, it's not unusual to see LDL cholesterol levels drop by 90%. So, I've had plenty of patients who have had familial hypercholesterolemia, have started with an LDL cholesterol north of 200, and using statins and PCSK9 inhibitors, we can get that down to 20 or 30, which is really tremendous. And it was unthinkable when I started my medical career, but now it's something that we do every day. So this is an exciting part of what we do, and an example of using a biological treatment, which has now been shown to be very safe and effective to help people that are at high risk for heart attack or stroke. Now, the other really interesting thing, this gets a little esoteric now, but it's something I like to talk about, is part of the technology is that we've learned how to do genetic engineering better. So both Repatha and Praluent are what's called fully human monoclonal antibodies. Now, we've used monoclonal antibodies in medicine for probably about 40 years, and the original discovery about monoclonal antibodies was back in the 1970s. And basically what people did initially is they took mice that made what's called plasma cells or B cells, and we combined them with a type of cancer cell called a myeloma cell. And the reason we use this myeloma cell is it's a cell that can reproduce itself and produce antibodies. It's a form of cancer where you just make antibodies. Now, we don't give patients myeloma cells, just don't worry about that. But we actually use that to produce the antibodies, since myeloma cells are built to just build antibodies. So over the years, we've been able to combine, we can give a mouse a virus or whatever it is that we want to give a mouse. The mouse develops a immune response to that. We combine the immune cells from the mouse with the myeloma cells, and that will produce a cell line that produces monoclonal antibodies. We don't give humans the cell line, we give humans the product of the cell line, which is the monoclonal antibody, which has been highly purified. Now, the problem with this in the past is that when you use mouse antibodies, our own human bodies know it didn't come from a human. So we start to develop antibodies against the mouse antibodies. But through genetic engineering, we've actually addressed that, and we have now genetically engineered mice that produce human antibodies. It's crazy, but there are now mice out there in labs that have human antibody genes in them. And they're happy mice. They run around their cages like all the other mice. You wouldn't be able to identify them differently, but they have the ability to produce human antibodies. So we take these mice with human genes and we create these hybridomas that you see, and you create a product now that is a actual fully human antibody, just like you or I would make. So that breakthrough is amazing. And it sounds crazy. It sounds like science fiction, but now these human antibodies have been used for a lot of people, for a lot of different diseases. And we have track record for using these antibodies now for over 10 years. And we're not seeing any negative safety issues. And we're seeing people have tremendous results and being helped from a number of different standpoints. So we are excited about this technology. And this is one of the many breakthroughs in molecular biology that have been so important in terms of developing newer drugs that are both safer and more effective than previous drugs. Another example of this is a drug that we've been very involved with called Inclisiran. And this is using another understanding of molecular biology. And this is the fact that our body has the ability to identify bad proteins and block the production of those bad proteins. So as I mentioned, PCSK9 is a bad protein. We don't need the protein to do well. In fact, I probably should have mentioned this, but there are people that just naturally don't make PCSK9. They don't have the genes to make them. And those people live completely normal lives, except they don't have heart disease and stroke. So they're actually human beings that just through Mother Nature were born without these PCSK9 genes or the ability to make PCSK9 genes. And we know that they live perfectly normal lives and just don't get heart disease or stroke. So we have a really good, what we call genetic model or natural history model, showing that people don't need PCSK9 to function normally. So by using the vaccines and other things to block PCSK9 production, there shouldn't be any concern, because basically we're taking people that make a lot of PCSK9 and turning them into the more healthy people that don't make PCSK9. That's an oversimplification, but it's fairly accurate. So getting back to the ability to block PCSK9, it turns out that we have the mechanism in our cells to block bad proteins. And all of our cells have this natural ability because of viruses. So we're hearing a lot about viruses these days. And what you don't hear so much about is that our body has really remarkable ways of fighting viruses. And one of the ways that our body fights viruses is that when our body understands that a foreign protein is trying to be produced, there are natural remedies in our cells to block the production of that protein. And that's what's called RNA inhibition. So people have figured out this whole genetic process, and now we have ways of programming cells in our body to block the production of bad proteins. And there's a drug that's been in clinical development that we've been working with really for the last 5 years called Inclisiran. Again, that has a great track record in terms of safety and in terms of lowering LDL cholesterol, well in addition to that you get on statins alone. So this is part of the whole new movement of not only blocking PCSK9 once it's being produced by our body, but actually helping our body understand to not produce it in the first place. So we're working with a number of different companies and different projects that are blocking our ability, blocking our body's ability to produce this bad protein PCSK9 by telling our genes that this is an unwanted protein, and this is a little piece of genetic code to help you understand that it's an unwanted protein. And just the coolest thing. It's really just quite remarkable. And again, we've dosed at this point hundreds or thousands of patients with these type of products, and we find that we can actually block the ability of the body to produce bad proteins. This is a picture, a complicated picture, but the take-home message is that this is a type of medicine that we're working on right now that will actually block the production of PCSK9 for 6 months after a single dose. So there's all, it just gets very, very technical, but there are many, many different ways to prevent your body from taking the RNA, which is the genetic code that will ultimately turn into a protein, and preventing that genetic code from being executed. So bringing it down to some more pragmatic and practical matters, let's just talk about what we can do to prevent a heart attack, including your first heart attack. So as I mentioned, probably our strongest strategy from a medical physician standpoint is lowering cholesterol. Between statins and some of the other products that I mentioned, we have really very, very strong capabilities of lowering cholesterol levels that have been absolutely proven to be safe and effective. And it's stuff that we do every day in cardiology practice. Lowering triglycerides seems to be helpful. There's been a little bit more controversy about this for a number of reasons. One, we haven't been able to lower triglycerides quite as effectively as we've been able to lower LDL cholesterol. And there seems to be different types of populations that have either more or less of effect from triglyceride lowering. But there was one recent study with a drug called Vascepa, or icosapent ethyl, which is a form of omega-3 fatty acid that had really remarkable results that showed, in addition to statins in patients with higher triglycerides, that people had a very profound effect in reducing heart attacks and strokes, and being able to do that very safely. Lowering blood pressure is important. Interestingly, lowering blood pressure is really quite effective at reducing stroke risk. It's harder to prove that lowering blood pressure prevents heart attacks, although if you get blood pressure under control for a long enough period of time, heart attack risk goes down as well. Smoking is a very modifiable risk factor. It's not easy for people who enjoy nicotine to get over it, but we have a lot of nicotine replacement products that are available, and a lot of strategies that can help our brain get over the addiction to nicotine. What I like to remind people is that burning tobacco is about the worst thing you can do. Nicotine in of itself is really not a bad chemical. Nicotine is the chemical that makes you feel good. It changes the dopamine levels in your brain. It gives you, has a de-stressing effect and a slight euphoric effect. That's actually not the bad part of it. But when you burn tobacco, you're inhaling 3,000 carcinogens and toxins, and you're bringing that up to very high temperatures where they can have really horrible effects on your lungs and your blood vessels. So me, like most preventive cardiologists, we're perfectly comfortable with people using nicotine replacement, be that nicotine replacement could be in the form of a gum, could be lozenges, could be patches, it's all different types of things. Vaping is a little bit more of a controversial issue. Vaping certainly has less toxins than smoking cigarettes, but the question is, do some of the vehicle, meaning the way that they dilute the nicotine in a vaping product, does that have toxic effects on the lungs? And there's a condition called popcorn lung that's been identified in vapors, which is related to the different chemicals that are in the vaping formulation, the preservatives, et cetera. So vaping probably is going to be less dangerous than cigarette smoking, but not as good as using other nicotine replacement products like patches or gum or lozenges. One of the simplest things that you can do to help yourself if you want to prevent a heart attack is to eat fish. And there's many studies that show that cultures that eat more fish have less heart attack and stroke. And there have been actual clinical intervention studies that showing that if you eat up to 5 portions of fish per week, your likelihood of a second heart attack is 25% less compared to people that eat fish infrequently. So I like to remind my patients that it's one of the simplest things that you can do to improve your risk. And keep in mind that the way you prepare the fish is also important. So certainly a deep fried fish is not as good as something that's lightly grilled, or even eating sardines out of the can, or eating tuna fish and things of that nature. So we have some very interesting and colorful discussions with the patient population about ways to make fish palatable, because some people love fish like me, other people are fish phobic and need a little bit of encouragement in order for them to eat it. But most people can find a way to eat fish that they'll enjoy when they think about it, and talk to somebody who has the nutritional and scientific background to help them figure it out. Increasing physical activity is certainly something that is very important. In my experience, the most important thing is really getting it in your schedule. So people that they're busy people will come home from a hard day at work, and the last thing they want to do is think about going for a walk or a bike ride or going to the gym. But it's important, and if you make it part of your schedule, then you can be effective, and it's been shown in many studies to reduce the risk of heart disease and stroke. And then we get into some of the drugs that have slight blood thinning effects. The most commonly used of these products is aspirin, and very effective in the right patients. I know there have been media reports that you may have heard saying that, well, aspirin isn't all it's cracked up to be, maybe we don't need aspirin. Well, let me just remind you that those reports concern people who are 70 years or older who did not have heart disease. And unfortunately, the media messages often get mixed up and a little bit confusing. But the reason aspirin didn't work in that population is because that population has a very low risk of heart disease and stroke. So if you can get to age 70 without a heart attack or stroke and don't have any risk factors like serious risk factors like diabetes, chances are you will live until you die without a heart attack and stroke. And if there's nothing to prevent, then other therapies like aspirin will not be effective, of course. But in people that have risk for these problems, aspirin is absolutely effective. And you should not, if your physician has prescribed aspirin, you should definitely not stop it without getting input from him or her. So what other interventions? Well, we talked about daily aspirin. We talked about statins. We talked about ezetimibe. We talked about PCSK-9 inhibitors. We talked about icosapent ethyl. And the one thing that we probably could talk about a little bit more is the Mediterranean style diet, which I'm a big advocate of. And this gets into the concept of the type of oils we use. So in the Mediterranean region, which is southern Italy, Greece, southern Spain, Lebanon, Israel, those places around in the Mediterranean basin, they tend to live the longest of people throughout the world. And the common dietary elements of people in that area is they tend to use olive oil as their principal cooking oil and their principal oil for foods. So it turns out that using monounsaturated oils, particularly olive oil, is much more helpful than other oils. So the take-home message here is that a Mediterranean-style diet, which has a lot of fruits and vegetables, people eat meat in the Mediterranean basin, but they have portion control. They don't deep fry their foods, and they use olive oil. So olive oil, also canola oil is not a bad oil, are going to be much more favorable than palm oil or coconut oil or corn oil. And so the type of oil that you use is important. And for my cooking at home, I almost exclusively use olive oil. Getting to the optimal weight, Mediterranean diet, stopping tobacco use, managing your blood sugar and blood pressure, and engaging in regular exercise. These are the take-home messages. And again, if all those lifestyle things don't work, then you come see me as a physician in my cardiology practice or in our research center. And in our research center, we're working on a lot of cutting-edge ways of helping people that have had very serious complications or people that have very unfavorable cholesterol profiles, and they have not responded to these traditional measures that I pointed out here, and we're helping them get to a more healthy balance and a lower risk by using very effective and safe drugs. Or we're testing them in the stages where we will look at you extremely carefully, including keeping you here overnight. When we use drugs that have less of a track record, we'll actually put people in our phase 1 unit and you get to spend the night with us. We call it Hotel JCCR. We have a few nice meals with us, get to watch Netflix, and enjoy the company of our really unbelievably fabulous staff and be part of the process of developing new products. And again, we'll watch you very, very carefully, make sure you don't have any side effects. If there was a side effect, of course, we take care of it. But over many years, we've been able to help a lot of people. And it's a great educational type of endeavor for people. It's very interesting. Virtually everybody that has done it has said they'll do it again. And they always find something to learn and something fascinating about it. And it's the way we move medicine forward. And it's actually fun. It's fun for me. It's fun for the patients. And it's actually fun for the staff to be part of the process of bringing cures to everybody else. And finally, we're in a state that has an older population, so we have some increased risk. But we also have a state that has a pretty darn good medical system. As you can see, that in the darker colors are the states that have the worst heart disease mortality. Florida is kind of in the middle of the pack, but we feel pretty good about it considering the fact that we have older patients here. And part of it is we have a very sophisticated medical community. But we'd like to turn that yellow to white, where we have virtually no heart disease mortality at all, based on the colors that are portrayed in this map. And I think the entire country would benefit from the work that we're doing here. So I think that's my last slide. And here's our Get Involved slogan and our website address and our phone number if you wanted to call and talk to one of our nurses or recruiters that can give you more information about things. So I guess I will take a pause with that and take some questions if there are any.
Yeah.
So you can just pull up some questions for me. Okay, how often should you get your cholesterol level checked? So again, that depends on your risk, but if you're at low risk, a yearly cholesterol check would be adequate. A lot of people that have a general physical every year will get general blood work every year, and a cholesterol level can be part of that. If your general cholesterol level is high or you have a particularly strong family history, then you're going to want to get a more sophisticated test. You can get what's called a lipid profile, where you look at the breakdown of cholesterol between LDL and HDL and triglycerides. And then some people will get what's called an advanced lipid profile, where we start looking at things like lipoprotein a. We start looking at the size of your LDL cholesterol or bad cholesterol and get into a lot more details. But for the general population, once a year is adequate. Now, if you're being treated or if you have a genetic condition, then you're going to get your cholesterol checked much more frequently than that. And the ultimate number of checks will be depending on how you respond to the treatment. And do you recommend any supplements to help lower cholesterol? Sure. Supplements can certainly work. It's interesting. The line between supplements and drugs is sometimes a little bit blurry. So there's a supplement out there called red yeast rice. You've probably heard about that. And interestingly, red yeast rice has the exact same active ingredient as lovastatin or Mevacor. And as I mentioned earlier, Mevacor was the first cholesterol drug to get on the market back in 1987. In fact, the developer of Mevacor, which was Merck, the drug company Merck, they tried to sue to keep red yeast rice off the market, but they lost that lawsuit because it was determined that red yeast rice was a nutritional supplement and not a pharmaceutical. So interestingly, you were able to get the active ingredient in lovastatin or Mevacor through a supplement. There are other supplements that help that prevent your body from absorbing cholesterol. They tend to have modest effects, maybe lower it anywhere between 5 and 10%, but certainly I would have no objection to those type of things. What physical exercise do you recommend to support heart health? So the key is to do nonstop aerobic activity. So any activity is good, but the best activity is when you go about it and you do it without stopping for at least 20 minutes. So the general recommendations right now is that we all should be physically active for at least 2 hours a week, and they should be in sessions that are at least 20 minutes long. So for most people, including myself, I shoot for 4 workouts per week. Each of the workouts will be at least 30 minutes, so I'll get over my 2 hours a week. I typically, I'll warm up a little bit for a few minutes, and then you do it at whatever I want, whatever I feel like doing that day. Actually, it's been a lot of bike riding lately because the gyms have been closed. I've become a very avid bike rider over the last 3 months, and I'm loving it, by the way. I'm not sure I'm going to go back to the gym so fast. And you just get in your schedule. You get in your schedule, and it becomes part of your routine. And you can go beyond 20 minutes certainly, but at the 20-minute mark, you start getting what's called a training effect, and that is very helpful in terms of long-term cardiovascular prevention. So I do recommend at least 2 hours a week of aerobic activity. And I also recommend that you do them in sessions at least 20 minutes long, preferably 30 minutes at least 4 days a week. Now, weight training is also fine. That has a number of positive effects in terms of bone health and other things. It has a little bit of cardiovascular benefit, but aerobic activity, which again is walking, biking, swimming, even gardening without stopping, anything that requires nonstop activity. Now, walking at a mall is a little bit different. So if you go to a mall and you're walking and you're on your feet, that's okay. But typically you walk, you stop at a window, you look at that, and you rest, and you walk to someplace else and you rest. And that's not quite as good as walking continuously. So people that like to walk in the town center or wherever it may be, I always recommend to them, do your shopping, and then after you do your shopping, then go for a 20-minute walk. And enjoy the facility, and you can walk through the facility, but that's going to be more heart healthy than just standing around for an hour, stopping and starting. So once you have high cholesterol and begin treatment, does it have to be continued, or can you reverse the disease? Very good question. And the answer is you can reverse the disease. It's very difficult to reverse, but it is doable. But you have to be very, very aggressive. We found is that when you lower LDL cholesterol to the 70 to 100 range, you kind of freeze progression of atherosclerosis. In order to reverse it, you have to get it below LDLs of 70. And as I mentioned, with the new products we have available, it's pretty common to get LDLs below 50, and we even get LDLs down to 10 or 20. So we're able to do that and actually reverse it. As far as continuing the therapy, that depends on your situation. So if you have a genetic condition, you'll always need to take the medication because your genes will be cranking out LDL cholesterol as soon as you stop using the therapies. For people that maybe have a poor diet, that change their diet, well, it's possible you can come off the therapies once you get down to ideal weight and you make major changes in your diet. But those are usually major changes. So for people who have had a heart attack that see the light and change their diet, they have to be willing to maybe go to like a complete vegetarian diet and get down to complete ideal body weight before it'll be safe and appropriate to stop the cholesterol medications. But it's not impossible. It's really not impossible. Any other questions? Well, again, it's been my pleasure and been a fun venue and hopefully educational for some folks out there. And we will have this information available on our website for your review at some point in the future. And again, we invite you to give us a call or to contact us via email. And we're more than happy to talk you through some of the really cool programs that are going on here and learn more about how to prevent heart disease and stroke. I much appreciate your attention. Thank you.